All right, everyone. We've reached time for this meeting to start here. So my name is Jeremy Berger. I'm a third-year medical student from LECOM and one of the programming committee members. I'll be hosting the hard skills meeting tonight, where we'll be focusing our attention on must-know fracture classifications. Knowing classification systems is key to doing well during audition rotations and beyond. This meeting will be recorded and later posted to the SAOAO Virtual Resource Center, so be on the lookout for further correspondence. We'll be batch posting our previous talks there soon. Without further ado, I'd like to introduce tonight's presenter, Dr. Gabriel Scrobat, who is a first-year orthopedic surgery resident for Mercy Health at St. Vincent Medical Center in Toledo, Ohio. Dr. Scrobat, thank you for being here. The floor is yours.
Thanks for having me, man. I'm glad to do this. Jermaine asked me to do this. He was one of the rotating students with us, and so happy to do it. Just to kind of know, I see there's like 20 high 20s in here. What are there first, second, third, fourth years? Yeah, just put it in the chat, kind of where you guys are at throughout med school. Okay, good. I'm seeing a little bit of everything. Lots of third years, which is good. So it looks like you're starting to prep for auditions coming up. Maybe you've had your first ortho rotation or you're going to have it sometime in the spring. But classifications are obviously orthopedics is based off of classifications. It goes a long way, and I'll just go to the next slide to just kind of start talking about it. But why do we have classifications? It one characterizes a problem for us. It helps us communicate among colleagues. So when I'm signing out to an attending, or when you're signing out to a resident and then an attending eventually, it helps guide prognosis. So certain classifications, depending on where it is in the classification, it's we do this type of surgery, we do this type of fixation. So it's makes it very concise, and the main thing is it guides surgical treatment. So classifications, which makes a useful classification, is that it actually helps dictate what we're going to do. There's a bunch of classifications that really has no surgical impact. It's more just descriptive, which is fine. But in the end, we're trying to figure out how to help somebody rather than classify their injury. So if we can, do it with a classification that's twofold, it's a lot more beneficial. And a lot of these names are, I hear a lot of attendings that I've worked with say just a bunch of old dead white men. So that's what they're named after. You'll probably hear that a lot along the way. And if you guys have any questions throughout the presentation, feel free to speak up or message in the chat. I'm no worries interrupting me. So first, one of the biggest classifications you probably maybe heard of is the Castillo-Anderson. So this is has to do with open wounds. It started with open tibial fractures, but mainly people use it for any type of open fractures at this point. And throughout this presentation, I highlighted the main things that are most important to see on these charts. So when you see an open fracture, you're usually just going to see it in the emergency department. The main thing is you got to wash it out, cover it, and immobilize it. And then you start to characterize how is that wound described. So there's the grades 1, 2, 3, and then there's A, B, and C of 3. Grade 1 is just a small little poke hole lacerations about less than 1 centimeter in size. That's usually, I have 2 slides here that kind of show different pictures. That's usually, a lower energy, not as much damage. You see this a lot with older people. They might have a tibial shaft fracture or something that, they simply just got by stepping down one too many stairs, and they have a small little poke hole fragment. Next would be grade 2, which is, any size anywhere between 1 and 10 centimeters. And then moving on to grade 3 with the A, B, and C, it's usually greater than 10 centimeters to begin with. But then when you go to grade B, it's about how you are repairing it and what kind of tissue damage that you're having. So the key word for Castillo-Anderson grade 3B is it requires a free flap tissue coverage or a rotational flap. That's a lot of things and a lot of times attendings want to hear rotational flap. That's what I've experienced along the path. And then finally, grade 3C is with any type of arterial bleeding. So here's kind of some examples. Can you guys see my cursor? on the screen? Okay, all right. So grade one is, a small little poke hole here. There's usually just a little bit of oozing coming out of it that can easily just be rinsed out with some, high pressure out of a small little saline bottle, and then just cover it up. Grade two, obviously anywhere between 1 and 10 centimeters. They can be pretty substantial lacerations still. And then 3A, pretty big laceration, wrapping almost kind of looks that at least half of the tibia here with exposed bone. And then 3B, you kind of see here, this is, after an X-fix has been applied. This is no way you're going to be able to get this closed. So this is where you would have to have a free flap or a rotational flap to bring down to cover them with musculature as well as skin. And then finally, 3C, this is usually a mangled extremity that, the foot doesn't have the extremity barely has pulses, and, they might have pulsatile bleeding, obviously something a little bit more urgent. So going back to kind of with antibiotics, of course, with any open wound, you got to have them with antibiotics. So tetanus, right off the bat, would for grade 1 and 2, you'd also do cephalosporins. And then when you get into more severe injuries, you could add into aminoglycosides. If it's a dirty, infected farm injury, talk about penicillins. Um, Obviously, very important for debridement. A lot of the times with these smaller poke hole lacerations, we tend to wash them out thoroughly in the OR and then close them, never have to come back to them. But usually when you get into the grade three, the three injuries that they usually do require multiple washouts depending on how bad the injury is. And of course, yeah, then if you're doing a flap, you have to just give time for the tissue that's there to heal and to be able to accept the donor. And one of the big things too is that this is only technically determined intra-op. I mean, it's kind of it's a fun little thing that people might get you on, but you can of course say what it is in the ED. And say, yeah, I think it's probably this type of this grade of Castile-Anderson, but mainly it's technically you can only do it intra-op. So moving on to the next classification, Freichmann for distal radiuses. This really isn't super high yield. I was talking to some of my co-residents, and we rarely ask about this. It's doesn't help dictate our treatment at all, so that's probably why we don't ask about it. But it's still something that people at other programs have asked, and I've been asked as well. So to simplify this is, here's your distal radius, and here's your ulna. So to begin with, type 1 is a transverse fracture of the distal radius metaphysis. So just straight across of the distal radius. And then a type 2 is just adding on an ulnar styloid fracture. So it's kind of, so these right here, 1 and 2 are the same, boom, an ulnar styloid fracture. Okay, so let's move to type 3, which is, a fracture of the distal radius that extends into the joint. So it's an intra-articular fracture at this point. And then going from 3 to 4, you're adding on an ulnar styloid. So this is how this entire classification progresses. Is it's kind of two things. It's 1 and 2, 3 and 4, 5 and 6, 7 and 8. It's all coupled together, and you could say the even numbers are just an addition of an ulnar styloid fracture if you're trying to like simplify it even more. So a type 5 is a fracture that extends into the distal radial ulnar joint. So it's actually the joint in between the radius and ulna, and then then 6 is with the ulnar styloid. So this classification really isn't super important in my opinion, but so we'll just kind of move on from this. The big thing about distal radius fractures is the surgical indications. This is something that you will get asked about a lot. And this is just a whole list of them. So I'll just read them out, and then I'll talk about a little bit the LaFontaine criteria. I don't have it listed, but there's some similar stuff in here with it. So the biggest predictor of does this fracture need surgery or not is the pre-injury radiographs. If it's super displaced, very comminuted, high likelihood you're going to have surgery to stabilize this because, depending if they're, 20, 30, 40, 50, or 60, they're probably active. They're going to need their wrist. And the best way to get them back to normal is by getting them fixation. So dorsal angulation greater than 5 degrees or 20 degrees compared to the contralateral distal radius. If there's any type of volar or dorsal comminution, so with comminution, the bones and a bunch of pieces on the front or back of the arm. If there's a displaced intra-articular fracture greater than 2 millimeters, you hear that a lot. It seems like a lot in orthopedics. Numbers kind of run together. 2 millimeters for intra-articular fractures in general is a surgical indication. You'll see that a lot with other things as well. If you have greater than 5 millimeters of radial shortening, so that means that your radius is shorter than your ulna, and then you'd have your wrist deviated, obviously, which is not good for functional outcomes. If you have an associated ulnar fracture, so a both bone forearm fracture, that's an automatic surgical indication usually, unless it's a kid. There's a whole different kind of set of parameters for kids, because kids heal like crazy. And then severe osteoporosis, if it's a volar or dorsal Barton's fracture. Then just, of course, there's just a few more. But something to look up later is LaFontaine criteria. It has to do with elderly individuals and if you should surgically fix them or not. It has to deal with the likelihood of the fracture falling off if you were to treat them non-operatively. So that's something you'll also get asked a lot. I highlight some classifications that we did not cover at the end that you should also look up too. Next, we're going to move on to ankle fractures, beginning with the Weber classification. It's the Danis-Weber classification, but everyone just says Weber. And then we'll talk about the Logie-Hansen, but this is a good start to get into it. So the fibula can be broken down into 3 parts of where it can fracture relative to the syndesmosis. The syndesmosis is this little band of tissue going right here. So a Weber A is anything below the syndesmosis or infrasyndesmotic. And then B is at the level of the syndesmosis or transsyndesmotic. And then Weber C is above the level of the syndesmosis or suprasyndesmotic. This, it comes in, you will get asked about this a lot. It's a very easy classification to know, but it plays a huge part in Logie-Hansen classification, which we'll get to now. So the Logie-Hansen classification is broken into 4 different injury patterns. The first word, so you see there's supination adduction, supination external rotation. The first word of each type describes the foot position at the time of the injury. And then the second word describes the movement of the talus in the ankle mortise relative to the tibia. And so these are predictable injuries that, I don't know why I always used to think this, that someone told me a while ago that they actually did this study by throwing cadavers down a staircase, which is not the case at all. I had to look it up just to be sure because I didn't want to say it, but I was under the belief of that for a long time. If they just hooked cadaveric ankles up to posts and then just manually stressed them. So it's not as exciting as an experiment as I thought it was. But so supination, adduction, or actually before I get into each one, with Logie-Hansen, think of it as a circle as you're going around the ankle. These injuries happen kind of in concession with each other as you're going around supination, adduction, supination, external rotation. You'll see there's different steps, and that's because these injuries, 1 happens first, then 2, then 3, then 4. So it's like you're going around the circle in the ankle. So for supination adduction, you have a talofibular sprain or distal fibular avulsion. More simply put, it's a distal fibular transverse fracture, which is they always tend to be a Weber A. So that infrasyndesmotic distal fibular fracture, and then next you get a vertical malleolus fracture. So plain and simple, Weber A, supination adduction is Weber A plus a vertical mal. These can, with all these words, you can get pretty complicated and hard to remember. So next is supination external rotation. This is by far the most common. 60% of ankle fractures that fit in this classification are supination external rotation. So if you aren't sure and you get asked, the best guess is SER. Just usually that's what you're going to see. So first you get a ATFL sprain, and then you get a short oblique fibular fracture. That's a Weber B fracture. And it's also important to know that it's an anterior inferior to posterior superior fracture pattern. So it starts down at the bottom here in the front, and then it goes up posteriorly, just in that oblique flat fashion. That's also something that you can get asked on as well. What's the direction of a SER fibular fracture? And then next, the third injury that you get with this is a posterior tibiofibular, PTFL injury or an avulsion in the posterior mal. And then finally, you get a transverse medial mal fracture. So SER is Weber B and transverse medial mal. And then next, we have our pronation injuries. So pronation abduction, abduction, is a transverse medial mal, and then a ATFL sprain, and then a Weber C injury. But importantly, with pronation abduction, it's a comminuted fracture usually. You'll see here both pronation injuries are both Weber C, so that's how you kind of differentiate the two. Excuse me, is pronation abduction is a Weber C. And then pronation external rotation is a transverse medial mal with an ATFL disruption, and then again a Weber C, but it's usually a transverse or short oblique fracture with a PTFL injury afterwards. So to simplify these, Loggy Hansen, I just made it more concise here. So again, supination adduction is a transverse medial mal with a Weber A, so that infrasyndesmotic. Supination external rotation, which is the most common 60% of the time. So if you don't know, just guess supination external rotation. That's a medial mal, a vertical medial mal with a Weber B. Then pronation abduction, transverse medial mal with a Weber C, which is comminuted. So there's a bunch of fragments, not a clean break. And then pronation external rotation is that transverse medial mal with a Weber C that is a transverse or a short oblique fracture. This website right here that I have linked is great at giving that step-by-step progression of how each of these individual injuries happen. Quite frankly, I still have to think kind of hard about how Loggy Hansen and how the mechanism occurs for each one time. So I think this is a great website. There's a bunch of great graphics that you guys could look up later too. So next, moving to IT fractures or intertrochanteric femur fractures. That is the Evans classification. There's not a whole lot to this classification, but it's definitely a highly asked topic. So with an IT fracture, your IT region pretty much goes from right here below your neck to technically 5 centimeters below your lesser. But so most IT fractures look like this, just straight little line going across from the greater troch to the lesser. How it's distinguished is between stable and unstable fracture patterns, and there's 4 things that really kind of say if this fracture is unstable or not. And with an unstable fracture, it's reverse obliquity. So you can see this fracture, the stable pattern appearing on this image right here is kind of going, lateral superior to medial inferior. The reverse obliquity is the opposite of that. So it's going medial superior to lateral inferior. So that's a big one, reverse obliquity, lateral wall involvement or lateral wall blowout. So comminution of this lateral area over here of the greater troch. This, you could say like this is kind of lateral wall blowout right here, where the comminution extends laterally. If you have posterior medial cortex comminution or the calcar, So the calcar is all kind of this area right here. So if you have any comminution there or fracture fragments, that makes it unstable. And then if you have subtroch extension. So what subtroch extension is 5 centimeters, that region is 5 centimeters below the lesser troch. So here's your lesser troch right here. So if you go 5 centimeters down, arbitrarily say here, down to where my cursor is at, if your fracture pattern extends down into the subtroch at all, it's considered unstable. So why do we care about if it's stable or unstable? Well, because that dictates our surgical treatment. So for stable fractures, we can do a little smaller device, you could say. It's usually either a sliding hip screw or a cephalomedullary nail. This is an example of a sliding hip screw. This is a DHS. This is um, an old implant that we still use today. It's not used a whole lot. I think I've seen two, maybe over the years. And then, or a cephalomedullary nail. And this would be a cephalomedullary nail. This is with a screw. There's also blades that people use as well. And then for an unstable fracture, then you would pretty much only use a cephalomedullary nail or intramedullary nail. They can be short or long. That's a very attending preference. The trauma docs that I work with usually only use long nails, but that's why stable or unstable really dictates on how we do the treatment, essentially. Next, sticking with the femur, is the Garden classification for femoral neck fractures. That is split into 4 categories. Type 1 is a incomplete fracture that is valgus impacted. That's the key word for type 1. So this little red mark right here, if you think of a valgus force coming on the femur, you're bending it, so that red mark is kind of the impaction zone. The fracture does not extend down any further. And then type 2 is a complete non-displaced fracture of the femoral neck. It's just kind of right here with this red line. And obviously it's non-displaced. So for type 1 and type 2, you have the options of open reduction internal fixation with 3 screws in an inverted triangle pattern, or sliding hip screw, previously, say, as I showed on the last slide. For type 3, it's a complete fracture with partial displacement. So you see the fracture line go all the way through. There's a little bit of gapping here, so it's partially displaced. And then type 4 is it's completely displaced. So 50% of it's off. Usually, if 25% of or anything is off, that you can visibly tell, you just say it's a type 4. So here's some actual radiographic images. It's kind of hard to tell unless you zoom in. But you can see, especially this one over here on the far right, that this is the inferior aspect of the neck, and then this is the inferior aspect of the head. This is not the normal congruity of a femoral neck. So for surgical treatments, Garden is a good classification because it helps us distinguish on what we should do. For type 3 and 4, our options are hemi versus total. So the question is why do we go from an ORIF or sliding hip screw to an arthroplasty, going from 1 and 2 and 3 and 4? The main reason is the blood supply to the neck can be very disrupted, as well as the synovial fluid that is surrounding the neck. Synovial fluid is not good at allowing bones to heal. That's why with intra-articular fractures that are greater than 2 millimeters, we tend to fix them because they're not going to heal on their own. There's enzymes in the fluid that prohibit bones from healing. So that's why we tend for types 3 and 4 to go to arthroplasty or a hip replacement. So the question is do we do a hemi or a total? Hemi is just replacing the femoral component, and a total is replacing the femoral as well as the acetabular component. And the reason how we decide that usually is the patient's activity level, as well as if the patient had prior hip pain. So that's something that early on I would always forget to ask the patient was, do you have hip pain, or did you have hip pain prior to this fall? Because if they're an older person that didn't have hip pain before, and there's elderly, they might actually benefit just from getting a hemiarthroplasty instead of going through resurfacing their hip completely. But if they did have hip pain, they obviously probably have arthritis to begin with. So if you're putting a new femoral head on and you're butting up against that bad cartilage, they're still going to have pain. So they're probably going to have to get a total hip eventually down the road. So further with these femoral neck fractures, you you also have these regions of where the neck can fracture. But sometimes people will ask you, there's three type subcapital right here below the head, transcervical kind of in the middle of the neck, and then basicervical right at the base of the neck, basi base. So that's just a couple of things, a few things that can kind of get you extra, know it points by just being able to know these terms as well. Any questions about any of that so far? Okay.
I've got a quick question.
Oh, yeah, go ahead.
With hip fractures, is there a particular approach that is desired, or is it just kind of based on the injury pattern?
Approaches wise, it's really a tendon preference. You know, uh, we fix some of my attendings fix hip fractures through anterior approach. A lot of people are moving towards anterior approach, posterior approach, what used to be the like gold standard approach that everyone would do. We don't do it a whole lot anymore. Usually it's a tendon preference, but sometimes body habitus, you can't go through an anterior approach with someone with a massive pannus, or if they have a bad yeast infection in their pannus, so you'd go lateral or posterior. So there's no right or wrong approach to do. It's just a tendon preference, really, or eventually your preference.
Great, thank you.
Yep. Next would be Salter-Harris. This is a big one for pediatric fractures. It's a fracture along the physeal growth plate, and there's 5 types. The easiest way to remember them is this is exactly how I remember it, is Salter. So type 1, it's a fracture through the actual physis. There might be a little shift medial or lateral, but it sometimes can be hard to see. There might be an extra little gap widening of the physis. And then above, or type 2 is above, which is where the fracture line goes through the physis up through the metaphysis right here. So you kind of have a little metaphyseal chunk involved in it, fracture. Type 3 is below, or it involves the epiphyseal plate as well as the epiphysis itself. So you got your metaphysis, epiphyseal plate, and then the epiphysis closer to the joint. And then type 4 is a fracture through through all the segments, the metaphysis, epiphyseal plate, as well as the epiphysis. Kind of just going in, some sort of a trajectory like this, but it involves all 3 spots right here. And then type 5 is a crushed physis. So this is a huge one that you can get asked on a lot. It can be kind of hard to tell too. That's why these little red lines are a good little description. And here's just some more x-rays showing of different ones. Obviously, you got kids have physes everywhere that they can fracture. So for type 1, this is just a good example of it's just slipped completely off. You don't really see any fracture, but it's definitely, you can tell the physis is disrupted here. Type 2, this one's kind of honestly hard to see, not being zoomed in. But then type 3 down here at the bottom left, you can see it involves the plate as well as the epiphysis going down right here into the joint. And then type 4 here in the far right, you can see the fracture line going up, and then it actually kind of extends right here into this little corner. And then type 5, it sometimes can be hard to see the compression of the physis. So sometimes that can be missed, but it can result in growth arrest through that physis eventually for the kid, obviously causing leg length discrepancies. Next, a huge one is Schatzker classification for tibial plateau fractures. This is one that you will 100% get asked to read fractures for. There's 6 types. I just try to simplify them here, and this is how I remember them. Type 1 is a lateral split. So here's the fibula. So this is how you know you're lateral. And so the split is just in the lateral condyle or lateral plateau, just extending from interarticular just straight down. And then type 2 is a lateral split depression. So you see this split as well as depression of the joint. Type 3 is a pure depression laterally. And then type 4 is any type of medial plateau by itself. Type 5 is a bicondylar, so involving both medial and lateral plateaus. And then type 6 here is the main thing is metapsio-diapsial dissociation. So you can have any type of fractures up here essentially at the joint, but if you have disassociation or where the metaphysis and diapsials aren't connected anymore, that's considered type 6. So I don't know how everyone at different programs do it, but our program we say 1, 2, 3 CT, 4, 5, 6 X-fix. So if it's a type 1, 2, or 3 injury, you can go ahead and get a CT when you initially see this patient. That's because there's not much reduction to be had. But for types 4, 5, 6, they can be pretty obviously a lot more severe of injuries. So and there's usually going to be a lot of swelling. There could be vascular issues that we have to address first. So a lot of times these guys get X-fixes because their skin's not going to be amendable. So then we get an X-fix and then CT that person because the X-fix helps us get a reduction and then we see actually where we're at. So here's just some X-rays. Here's a lateral split here. You can see it extending from here, from the joint all the way down. Here is a type 2 here. You can see the split depression. And then type 3 is just a pure lateral split, lateral depression. It's hard to tell, but you can see the congruity of the medial plateau, and then the lateral kind of stoops down lower. And also the medial plateau is normally the lower joint of the two. So that's obviously, you can tell there's something going on here. Here, type 4, you can see that the medial plateau is just disrupted here. There's no lateral involvement here. Type 5 is, you can see both plateaus or medial and lateral are involved. And then 6, this is just blasted. You see there's no true congruity of bone going up through to the plateau from the diapsis. So 1, 2, 3 CT right away, 4, 5, 6 X-fix. It looks like I missed that question. Is there any downside to doing a total arthroplasty to avoid a possible second surgery in the future? No, there's no downside to that. It's just kind of when you're doing a hemi versus a total, a lot of times with elderly people that aren't as active, that they don't get around a whole lot and they just need something that's going to provide them pain relief as well as stability. A hemi is usually the way to go. It's a little less invasive of surgery. Some people say that with a hemi, it gets the patient off the table quicker. Sure, it does, but that's really not the biggest issue with surgery for elderly people that are unstable. It's really going under anesthesia. So it's not that big of a deal if you end up doing a total hip. But a lot of the times with the older non-active patients, we just go ahead and give them a hemi. If they're a younger active patient, we do a total. So next is the Young Burgess classification or pelvic ring injuries. This is another big one that obviously only happens in traumas usually, or they can happen in adult fragility or elderly fragility fractures. Um, so first, we'll talk about APC, or anterior posterior compression. An APC type 1 injury is simply just pubic diastasis widening less than 2.5 centimeters. So you can see this kind of little gapping right here they have on the diagram. It's less than 2.5 centimeters for type 1. Type 2 is pubic diastasis greater than 2.5 centimeters, not meters. That'd be pretty big. So symphysis widening greater than 2.5 centimeters, anterior SI joint diastasis, so the anterior ligaments of the SI joint where it's gapping, it's widening, and then you have disruption of the sacrospinous and sacrotuberous ligaments. So I always just think SSST is disrupted in type 2, because honestly, those sacrospinous and sacrotuberous just get too hard for me to say very quickly. So that is type 2, but with type 2, your posterior SI ligaments are intact, and that's the big distinguisher between type 2 and 3 for APC. Type 3 is it's everything that was previously stated with disruption of the posterior SI ligaments. And so that's considered an SI joint dislocation. You can see here that there's nothing holding all the way back to the posterior SI joint intact. Your posterior ligaments of your SI joint are the strongest ligaments within your SI joint, so that's always a good fact to know. And then with APC injuries, the biggest concern is intra-abdominal bleeding or intrapelvic bleeding, because your pelvic ring is normally only such a volume, but when you have high energy trauma that allows an extra or more volume to be had in that area, and you're bleeding internally, your body will just fill that area with blood because it wasn't able to fill that area before. So you can lose a ton of blood in your pelvis if you have usually with an APC3 injury. And so this is where you would use a pelvic binder. And that can really cause people to, at least it decreases the volume of the pelvic ring that's able to be had, and as well as just kind of keep any more blood from going in there just because of the pressure differences from the vasculature. And I've, quite a few times already this year, we've patients come in with a pelvic binder, and you have to take it down when they're in the ED or in the trauma bay to make sure that their skin's good, there's no open injuries or anything. And I've seen, we take it off, and 10, 20 seconds later, this person's blood pressure tanks. And then we're like, oh shoot, we got to get it back on. And they give them, they're already running blood and fluids at that point. But it's pretty crazy how fast this can happen. So here's just X-rays of the APC injuries. So this is kind of what just simple pubic diastasis looks like. Obviously, there's no measurement here, but less than 2.5 centimeters. For APC2, obviously bigger widening that you can see here. If you're going back to the left SI joint, you can see that there's disruption anteriorly. I know we can't see the posterior too well, but here in the CT scan, you can see that to where it is disrupted anteriorly. Posteriorly, there's a nice congruent joint still. You can see the widening's mostly in the front. And then boom, APC3 is this huge injury. You have a dislocation back in the back. You can see it's disrupted all the way right here from the front to the back of the SI joint. Major trauma to that pelvis. Next is lateral compression within the same classification. So lateral compression is, think of it as the word. So something's getting hit from the side. You could think of somebody getting T-boned directly on their side. So compression is coming in directly laterally. Type 1 is an oblique or transverse rami fracture here. So I mean, it can even be comminuted, really, but it's a rami fracture here, superior, inferior, with an ipsilateral anterior sacroiliac compression fracture. So sacroiliac kind of live at the top of the sacrum. So it can be kind of hard to see sometimes, especially until you're in a CT scan looking at images. Um, so that's type 1. You have a rami fracture with a ali fracture. Type 2 is a rami fracture with an ipsilateral posterior ilium fracture dislocation. So that's also a crescent fracture. So, here's your type 1 right here. In addition, now you're adding the crescent fracture or the ilium fracture. Next is LC3, which is the ipsilateral compression fracture. So it's pretty much everything that we've had over here already, with a concomitant APC fracture on the other side. So we call that a windswept pelvis. That is another word that can be highly asked of, what would you call this type of pelvis with this lateral compression injury? Very devastating injury. And the big difference between APC and lateral compression when you're in the trauma bay trying to treat this patient is lateral compression should not get a pelvic binder, because thinking of the mechanism of how this happened, they had a lateral force causing this injury. Well, a pelvic binder causes a lateral force to wrap around the pelvis, which would further possibly injure this patient. So definitely not a good idea to be using that. A lot of times with lateral compressions, it can be linked with TBIs, traumatic brain injuries. And then also in this classification is vertical shear. So, osteopathics like mines, we use with OMM all the time. Learning was the vertical shear of, an OMM lab. So it's simply that. It's just, everything is just posterior and superior directed force. That's just, lifting the whole hemipelvis kind of superior. So here's just some images. So you can see here the rami fracture, and then right here is a small little ali fracture, a type 2. So actually here on the CT, you can see the ali fracture a lot better. But then here is the crescent fracture that extends all the way through the ilium, through the joint and out the opposite cortex. And you can see it better here as well, extending all the way up. And then an LC3, it's kind of hard to see on this image, but you just see this entire side is just compressed in with opening on the right side. And then vertical shear, looking at this purple line, obviously you see there's a big injury here. So next is the NEAR classification. NEAR has quite a few different classifications, but for him or for them, we're going to cover the distal fracture. He also has the proximal humerus fracture that I have as a slide at the end, just to, another classification to look up. But for this distal clavicle fracture, a type 1, I have all the kind of the key words highlighted, is a fracture lateral to the CC ligaments. So your CC ligaments are these two guys right here. You have your conoid ligament that is more medial, and your trapezoid ligament that is more lateral. So you can, this picture kind of distinguishes them better. And how I always remember those are conoid is closer to the body. So C closer, however you remember it, great. But that's just how I did it. There's distances that you'll get asked. The trapezoid is 3 centimeters from the AC joint, and the conoid is 4.5 centimeters from the AC joint. There's just so much to learn over the years that is going to help you, and you'll learn throughout your auditions and looking at pocket pimps. But so anyways, back to type 1, it's a fracture lateral to the CC joint. The conoid and trapezoid ligaments are intact. So you can see here's one. Type 2A is a fracture medial to the CC ligaments with both your conoid and trapezoid intact. Type 2B is a fracture between the CC ligaments And you can have the conoid torn for one of them. For 2B, you can have the conoid torn as well as the trapezoid intact. And then if you have a fracture for type 2B that occurs lateral to the CC ligaments, that would be both conoid and trapezoid would be disrupted. And then type 3 is an interarticular fracture occurring lateral to the CC ligaments. So you kind of see here, the fracture is lateral to these two ligaments, and then it extends into the AC joint. Type 4 is a physeal fracture that occurs in a skeletally immature. So you kind of see right here, it goes right through the physis. And then type 5 is a comminuted fracture with the CC ligaments both intact. And then you kind of see here that we have them classified, 2B or 1 is stable, 2A is unstable, 2B is unstable, 3 is stable, 4 stable, 5 unstable. So you see here just kind of more description of, what is an operative clavicle, what's a non-operative clavicle. This is a good way to guide treatment, but in my experience, it's a tending preference. If you have some old school guys, they're like, oh, no, that's going to heal just fine, nothing to do with it. Then, some of my trauma tendings, they will fix any clavicle because, it gets people back to living their life a lot quicker. We had a patient that broke his clavicle a few weeks ago, and then ended up getting it fixed and playing in a state tournament game, the state championship. So obviously fixing these clavicles gets people back to what they want to do right away. Weight bear is tolerated right away. We say no more than push-ups or bench press for quite a few weeks, but anything besides that, go ahead and live your life. So it's pretty impressive by being able to fix these clavicles, but absolute indications that you will get asked on or asked about for surgery is skin tenting or essentially an impending open fractures. That's what skin tenting is. Or obviously if it's open, definitely needs to get it fixed. If there's any type of artery or vein injury, if there's a floating shoulder, so a floating shoulder is a distal clavicle with a scapular neck fracture that has greater than 10 millimeters of displacement. So obviously, if you have a clavicle and a scapular neck fracture, your shoulder's floating. There's no stability there. Your range of motion your function is very limited. Obviously, going to be very painful. And then relative indications for operative fractures would be, unstable fractures, as I said, of 2A, 2B, and then type 5. If there is a brachial plexus injury, you could do surgery on it. If there's any type of head injury, seizure disorders, and then polytrauma patient, that's a big one. That usually if they have a femur fracture with a tibia fracture, as well as a clavicle fracture, you will go ahead and fix it because they're going to rely on that shoulder to help them with crutches or a walker. So usually with polytrauma patients, you pretty much fix every bone that's broken on them, just because you don't know what is going to be the hardest for them to recover, and they might have to rely on the other limb more so. Next is the Gartland classification. This is with pediatric distal humerus fractures. So there's a bunch of different. You can see there's at first I only learned types 1, 2, and 3, and then there's a type 1, 2, 3, 4, and then now I was talking to one of my chiefs the other day, and we were talking about Gartland, and he was like, "Well, a lot of times people are just classifying as it's stable or unstable, and that's it." But for students wise, you're going to be expected to know the Gartland classification. So you can sound smart by saying, "Oh, well, now it's only stable or unstable." but you should know 1, 2, 3, or 4. So type 1 is a non-displaced fracture. So, here's the humerus, here's the ulnar and radius, the elbow joint. A non-displaced fracture, that's this little red line going across for type 1. Type 2 is displaced with the intact posterior hinge. So the anterior surface is gapped or disrupted with the posterior portion of the cortex still intact. Type 3 is displaced completely. It's the anterior and posterior cortices are disrupted. And then type 4 is a complete disruption with instability of flexion and extension. Here's a example of type 1. You can kind of see a little fracture. Type 2, you can see the anterior cortex is disrupted. Posterior looks good. So type 2 there. And this is probably a type 4. I mean, it's not even in the ballpark. But things to know for Gartland classification or really just supracondylar injuries is how the injury most commonly occurs, as well as the most common nerve injuries that happen. So the extension type, where it's a fall on an outstretched hand, is the most common. It's almost 98% of the time an extension-related issue or injury. With the most common nerve injury is your AIN. So it's important when you go and learn these classifications to know, what position is the arm in, and then depending on the type of displacement and which positioning, that's how you get your nerve injuries. And those are very highly tested things that you should for sure learn throughout these next year or couple years. And then we have the Milch classification, which is for single column lateral condyle fractures. So here's your lateral condyle, medial condyle, the elbow, your radius, ulna. Your radius is always lateral in a normal image. So that's to kind of give you a reference point. And it has to deal with the trochlear groove of how the fracture extends through it. So for type 1, the fracture passes lateral to the trochlear groove into the capitular trochlear groove area. So you can kind of see here, the fracture is extending down here. The trochlear groove is right here, so it hasn't reached that area yet. So that's a type 1. A type 2 is a fracture that passes through the trochlear groove at its apex. So you can see this fracture line come down from the lateral condyle and extend into the trochlear groove. So you can kind of see that here. The trochlear groove is right here. This fracture line does not extend into that point. And then here, obviously, this is a more immature patient just by looking at how much growth plate and cartilage. I mean, there's a huge gap here, not much left here. But you can see this fracture extends down, following my cursor down into the trochlear groove. And then it is the last classification we're going to go over in detail tonight, is the Jupiter classification. This one is definitely one to know, but not one for surgical planning a whole lot. It's just a 2-column distal humerus fracture, so medial and lateral columns. You have your 1, 2 is your high T, low T. So high T, the T goes up higher into to the proximal humerus, and then this is a lower T, it's more distal. You have your Y, which is a oblique fracture line through both columns with a distal vertical fracture line. So here's your distal vertical fracture line right here. Then you have H, and then a medial lambda, and then a lateral lambda. So that's kind of how I remember. I did high T, low T, YH, medial lambda, lateral lambda. I really didn't get asked a whole lot about this just because it's not used for surgery a whole lot. Usually if you got a pretty significantly fractured elbow or distal humerus, you're going to be fixing it. So, and it doesn't really, affect on how you're going to plate it. You're probably going to dual plate it depending on how the fracture line extends. It's not like it's for a high T, you're always using a lateral plate or a dual plate. It can vary, and it's of course very attending specific, or dependent really. So I included a slide of other classifications that we didn't go over, but are still very important. So there's just however many more. There's almost 10 classifications I added here that as you're learning, make sure you pay attention to. You will get asked on them, and there's a lot to learn with orthopedics. There is so much. There's classifications, anatomy, as well as just kind of learning the approaches. There's so much to be learned. That's why they say orthopedics is a 5-year residency program, and thank God it is, because I'm 6 months in, and I mean, sure, I've learned some, but there's a heck of a lot more to learn to be more comfortable, with being able to do this on my own one day. So I'm happy to answer any questions you guys have, whether it just be general questions or something about the topic. Feel free. This is a great time. So thanks for having me, guys.
I have a question about like upcoming interviews. I'm a fourth year. Just like trauma scenarios, preparing for those. Do you have any like resources that you use that really helped you, or anything that you think is like very needed?
Resources for, are you saying like almost like they're having you read fractures usually?
Yeah, so like I heard that like some interviews are gonna do like we practice. I'm at Francescan right now, and we practice like a um three scenario where like you have people come in and then you read the fractures and then you pretty much like dictate management, just kind of going through those. I don't know if you had those on your interview trail. I heard they're pretty common.
Yeah, they're pretty common where they give you some fractures to read and maybe some scenarios of who you would treat first. I don't I mean I used Anki a lot for the Pocket Pimp book. I thought that was a great resource, but I think make sure you know your classifications. I mean, I'm sure you do by now. You've read plenty of radiographs. Just if you're trying to decide who should go first, make sure if makes deciding if the person's neurovascularly intact, if it's an open or closed injury. Of course, if they aren't neurovascularly intact and it's an open injury, that's pretty acute. If it's a dislocation, that bumps it up in the line. A pelvic bleeding injury. But an elderly person with a hip fracture, with an IT fracture, that can sit in the ED for hours. You don't have to go see that. So, just think about like don't stress about it too much. It doesn't have to be perfect, because you're not going to expect it to be perfect. But as long as you have a good thought process of why you're doing that, I think you'll be just fine. So I don't have any true resources. Of course, OrthoBullets is like the #1 resource. I'm sure there's probably resources out there that might do kind of scenario-based situations, but off the top of my head, I don't have anything exactly.
Cool, man. Appreciate it. Thank you.
Yeah.
Gabe, I'll offer a question. Do you have any recommendations for people that are trying to schedule and set up audition rotations, either words of wisdoms or things you wish you would have done different, kind of looking back on it?
If they're trying to set up audition rotations, I think there's all these different things you can do, because you can set when you're applying geographic preferences. I would really look at a program and see what you want out of it before applying. I wanted to go to a level 1 trauma center because I wanted to be able to see everything. So I tried to go to a lot of places that saw trauma, but also talk to people, talk to other students or residents that you might have met along the way before you. Reach out to them. Definitely reach out to them, because we do talk about students and say how involved they are or active they are trying to pursue us. So when you're applying to places or trying to find these auditions, of course, location is important for you. At least it was for me. What that program has to offer, kind of, are you going to have to travel a lot for this residency program? Or are you centered in one location the whole time? That can be good or bad. You could only be seeing certain physicians work for all 5 years, or you can go out, for a while and see other people work and other residents work. And then, if you're trying to get a audition spot somewhere, definitely reach out to them. If you're very interested, continue to reach out to them if they're not getting back with you. I know some programs aren't the best about the coordinators getting back. So just be persistent, especially if you're interested in a place. There's nothing wrong with trying to reach out to a program director. Don't kiss them too much, kiss their behind too much, but show you're interested. And I mean, that's what they want. They want somebody at their program that wants to be there as their first option and not their 10th option. And something that's always stuck with me when this happened. This was all the way back when I was applying for med school. Was somebody said to me at my interview was like, don't stress that much because they want you as bad as you want them. Because every program wants a good student or a good resident, and every resident or student wants a good program. So if you kind of put that aside, things will work out.
If I could do a follow-up to that one, seeing how, we have you here as a resource for Mercy Health, what are the best parts of your program, thus far? Like you said, trauma one, that's not always the case. So that's clearly a pull. What other things do you guys have over there at Mercy?
Yeah, I mean, I think I'm very pleased with my program. With obviously level 1 trauma is great. We see it every single day. When we're not, it's for just for intern's sake. But when we're not on ortho services, we're still doing ortho. We still take call. Some people might not see that as a benefit, but in my mind, I do. I mean, I'm fine with work still doing ortho when I'm supposed to be on an off service because I'm here to do ortho. Also, we get hands-on super early. I think my 3rd month was my plastic surgery month. And it's plastic surgery / hand. And these our docs let us, we do the hand surgeries. So early on, we're doing carpal tunnel, trigger finger releases. I was being walked through a digital nerve repair with using a microscope. It was definitely tough, but we got through it. So there's the plastic surgeons. They're always like, time on the tools, man, time on the tools. So they see the importance of us getting hands on early. The camaraderie, I think, were great. As like especially our younger group, or the juniors, because the 1s, 2s, and 3s, we work together a lot. We get together a lot outside of our the hospital, which I think is great. So like St. V's, I think is a great place to learn. It feels like a family. It feels like a family hospital, but it's not at all. It's a big hospital. We see, the worst of the worst stuff that comes in our area. And our program director, Dr. Phillips, is going to become our new program director. And he's an amazing teacher. I know there's probably maybe some students that have rotated here that are in the call with us, but he's amazing teacher. Dr. Boothby is amazing teacher. It's just everyone, all the attendings want to teach, which I think is awesome. And so I'm very fortunate to be here and where I'm at.
Thank you.
Can you go through your programs, like education setup, and then like how much you guys have to travel, whether that be for off service or rotations or any, peds, onc, whatever it is. Can you talk through those?
Yep. So for the education standpoint, we have education every day. It's Mondays, every day starting at 6 a.m. Mondays, Tuesdays, and Fridays are 6 to 7 a.m. Wednesdays and Thursdays are 6 to 8 a.m. So 2 hours on those days. It's standard. It's either going to be an hour lecture on peds, spine, sports, where we read articles. We have old alumni Zoom in for our hand lecture every other week on Thursday mornings from 6 to 7. And then on the opposite week of that, we have an alumni Zoom in for foot and ankle things. And then on Fridays, we have either trauma didactics, to where the trauma attendings will come in and will review articles, or the trauma doc will have prepared a dissection for us that we'll go through for approaches. We have trauma conference every Thursday. We have on Wednesday mornings, we have the Miller book that we read. It's kind of our exam for the week. We're given pages to read, usually about 15 to 20 pages each week, and the chiefs will ask us questions for that hour. It's good. It keeps us on our toes. So for that, and then also we do anatomy. We're in it now every Monday from 6 to 7 for 18 weeks. The second years present anatomy to the residency, to where they're doing just general anatomy, bony anatomy, as well as approaches. So it's great for the second years to truly learn and be able to present it. And then for out rotations, we do go out. Third year, we go out for 4 months for a pediatric rotation in Dayton. Everyone comes back. They say it's the best experience going out to Dayton. They see so much. It's a great children's hospital. And then fourth year is the year that we kind of like ghost away. We're here for parts of the year, but then 6 weeks we go down to Ohio State for oncology, which is, we see the huge hemipelvectomies, huge cancer cases. And then we also do 3 months at Metro in Cleveland for our hand, another true hand rotation. And that's also a great experience, because you see, run-of-the-mill hand stuff as well as trauma, being downtown Cleveland. And I think that's it. So we only go, 3 places during this time. And it's, a little bit of third year and some of fourth year. The rest of the time we're here at Bees, or in the Toledo area.
Sweet, man. Thank you. That education sounds great. That's the first time that I heard of a program that does like an 18-week kind of like build up course. I think that's very valuable. That's cool. Thank you.
Yeah, no problem. Yeah, it's super valuable, and we have each year you get a fresh cadaver for it. So I think we're maybe in like our fifth or so week of it. And it's good. It's great. It's I'm learning as an intern, getting to watch it, because of course my anatomy knowledge isn't as good as the second years. And then it's kind of gets us, the second years, it seems like, over the hump of, okay, like, I got my anatomy down, like now it's really time for me to really, dive into surgery. I know what I'm talking about. So I think it's a great confidence booster, as well as education standpoint, that not a lot of places get. Any other questions?
Thanks for your time. Appreciate it.
Yeah. No problem, guys.
All right. So if we don't have any other questions, we'll conclude here. Thank you so much, Gabe, for giving your time to us. We know that you're incredibly busy as a resident, even more so than us medical students. So thank you so much.
Yeah, no problem. Glad to do it, guys. Good luck to all of you.